In this lecture, we'll be discussing about the treatment of cataract. Now, the final mode of treatment for cataract is the removal of the cataractous lens. Now, this can be done via two techniques. The first is the intracapsular cataract extraction, and the second is the extracapsular cataract extraction. Now, in intracapsular cataract extraction, the entire cataractous lens along with the intact capsule is removed. Now, this is not done presently. This was a technique used a long time ago. Now, the indication for ICCE, that is intracapsular cataract extraction, at present is only the markedly subluxated and dislocated lens. So if a patient comes to you with cataract, the mode of treatment always is extracapsular cataract extraction. Now, if that patient has a markedly subluxated or dislocated lens, then ICCE is done. Okay, so again, intracapsular cataract extraction, here the entire cataractous lens along with the intact capsule is removed. Now, in extracapsular cataract extraction, major portion of the anterior capsule with epithelium, cortex and the nucleus is removed, leaving behind the intact posterior capsule. Okay, so again, the majority of the portion of the lens, that is the anterior capsule with its epithelium, the cortex and the nucleus is removed, but the posterior capsule is left intact. So the basic difference between intracapsular and extracapsular is, in intracapsular the entire lens along with the intact capsule is removed, whereas in extracapsular cataract extraction, the posterior capsule is left intact, whereas the other structures like the anterior capsule, the cortex and the nucleus is removed. Now, the extracapsular cataract extraction is a commonly asked short essay or a short note. Now, the surgical techniques of ECCE, it includes conventional ECCE, manual small incision cataract surgery, also known as SICS, small incision cataract surgery. The third is phacoemulsification, which is the most common mode of treatment, and the fourth is femtosecond laser assisted cataract surgery or FLACS. Okay, so the surgical techniques of ECCE, extracapsular cataract extraction, it includes conventional ECCE, manual small incision cataract surgery or SICS, phacoemulsification and femtosecond laser assisted cataract surgery or FLACS. Now, of these, the SICS and phacoemulsification is the most commonly asked questions. Now, let us look into the surgical steps of manual SICS. Now, the first is the superior rectus bridle suture. Now, it is done to keep the eye fixed in downward gaze. Now, the eye is then washed with betadine or Ringer solution and topical antibiotics. So this is the first step, that is superior rectus bridle suture and washing of the eye with betadine, Ringer solution and topical antibiotics. The second step is conjunctival flap and exposure of the sclera. A conjunctival flap is made with the help of a sharp tipped scissors along the limbus from 10 to 2 o'clock positions. Okay, so the first is superior rectus bridle suture, the second is conjunctival flap and exposure of the sclera, and it is done from 10 to 2 o'clock positions, and it is done with the help of sharp tipped scissors. Now, the third is hemostasis. Now, once there is exposure of the sclera, there is bleeding can occur. Now, to stop this, hemostasis is done, and this is achieved by gentle wet field cautery. Now, the fourth is the sclerocorneal tunnel incision. Now, this is the most important step. Now, the sclerocorneal tunnel incision, it is around 5.5 to 7.5 millimeter in length, and it consists of the following components: the external scleral incision, the sclerocorneal tunnel, which is made using the crescent knife, and the internal corneal incision, which is done with the help of the angled keratome. Okay, so we have the external scleral incision, the sclerocorneal tunnel, and finally the internal corneal incision. Now, the sclerocorneal tunnel is made with the help of the crescent knife, whereas the internal corneal incision is done with the help of the angled keratome. So this is the sclerocorneal tunnel incision. Now, the fifth is the side port entry of 1.5 millimeter length. Now, this incision, it is made at the 9 o'clock position, and it helps in the aspiration of the cortex and deepening of the anterior chamber. So this is the importance of the side port entry, that is aspiration of the cortex and deepening of the anterior chamber. Then we have the anterior capsulotomy, that is the anterior capsule is slowly removed. Now, it is usually done there are various techniques, and the most commonly used is the continuous circular capsulorhexis or CCC, continuous circular capsulorhexis. Now, here when the lens, it is removed in a circular, the anterior capsule of the lens, it is removed in a circular manner. So this is the anterior capsulotomy. That is, the anterior capsule is torn in a circular fashion with the help of the capsulorhexis forceps. So this is the sixth step. So till now we had the superior rectus bridle suture, then conjunctival flap and exposure of sclera, hemostasis, sclerocorneal tunnel incision, side port entry, and anterior capsulotomy. Next is hydrodissection. Now here, balanced salt solution, it is injected under the peripheral part of the anterior capsule, and this is done to separate the corticonuclear mass from the posterior capsule. Okay, so remember, in extracapsular cataract extraction, the posterior capsule is left intact. So in the next step we do hydrodissection, where balanced salt solution is injected, and this separates the corticonuclear mass from the posterior capsule. Now the next step is nuclear management. That means we remove the nucleus. Now it involves the prolapse of the nucleus, which is aided by hydrodissection, and the second is delivery of the nucleus through the sclerocorneal tunnel, and this can be done in a number of methods, and some of the methods are phaco sandwich technique, phaco fracture technique, and fish hook technique. Ninth is the aspiration of the cortex. Now the remaining of the cortex, it is aspirated out using a two-way irrigation and aspiration cannula from the main incision or the side port entry. Then we have the intraocular lens implantation. Now a posterior chamber intraocular lens is implanted in the capsular bag after filling the bag with viscoelastic substance. So we remove the cataractus lens, and we place a pseudo lens, that is an intraocular lens, in the place of the cataractus lens, so vision can improve. The next step is removal of the viscoelastic material. Now it is done with the help of a two-way irrigation aspiration cannula, and the reason we remove the viscoelastic material is because excessive left-out visco material may cause secondary glaucoma, and the viscoelastic material used is sodium hyaluronate. And the final step in the surgical small incision cataract surgery is wound closure, and here the anterior chamber is deepened with balanced salt solution injected through the side port entry, and this leads to the self-sealing of the sclerocorneal tunnel incision due to the valve effect. Okay, so let us revise the steps in small incision cataract surgery. So the first is a superior rectus bridle suture, and this is done to fix the eye in downward gaze. Then we have the conjunctival flap and exposure of the sclera. So the conjunctival flap is made, and there is exposure of the sclera, and the flap, it is made using sharp tipped scissors along the limbus from 10 to 2 o'clock positions. Next is hemostasis. When we expose the sclera, there is bleeding occurs, so we do hemostasis using wet field cautery. Then is the most important step, that is the sclerocorneal tunnel incision. Okay, now remember the length, it is around 5.5 to 7.5 millimeter in length, and it consists of the external scleral incision, the external scleral incision, the sclerocorneal tunnel, and the internal scleral incision. The sclerocorneal tunnel is made using the crescent knife, and the internal corneal incision is made using the angled keratome. Okay, so we made the sclerocorneal tunnel incision. Then we do a side port entry of 1.5 millimeter, which is made at the 9 o'clock position. Then is the anterior capsulotomy. So once all of this is done, the lens is exposed. Now the anterior capsule of the lens is removed with the help of the CCC, that is continuous circular capsulorhexis. Okay, so this is anterior capsulotomy. Then we inject fluid, that is we inject balanced salt solution to separate the corticonuclear mass from the posterior capsule, and this is done using the balanced salt solution. So the steps till now is superior rectus bridle suture, conjunctival flap and exposure of sclera, hemostasis, sclerocorneal tunnel incision, then side port entry, and anterior capsulotomy and hydrodissection. Next is the management of the nucleus, and this is done with the help of two maneuvers. The first is the prolapse of the nucleus, which is aided by hydrodissection, and the second is delivery of the nucleus outside through the sclerocorneal tunnel, and this is done with the help of certain few techniques like phaco sandwich technique, phaco fracture technique, and fish hook technique. Next is the aspiration of the cortex. Now the remaining cortex, we've removed the nucleus. Now the remaining cortex, it is aspirated out through the two-way irrigation and aspiration cannula from the main incision or the side port entry. Next is the intraocular lens implantation. Now from where the cataract lens is removed, the new or pseudo lens is placed, that is within the posterior chamber of the eye itself. So we've placed the intraocular lens. Now remember, it is done after filling the bag with viscoelastic substance, and the viscoelastic substance used is sodium hyaluronate. The next step is removal of the viscoelastic material, and it is done with the help of two-way irrigation aspiration cannula, and this is done to prevent secondary glaucoma. And the final step in SIC is the wound closure, and this is done by injecting balanced salt solution in through the side port entry, and this leads to self-sealing of the sclerocorneal tunnel incision due to the valve effect. So these are the steps in manual small incision cataract surgery. So again, as a final revision, the steps are surgical rectus brittle superior rectus brittle suture, conjunctival flap and exposure of the sclera, hemostasis, sclerocorneal tunnel incision, remember the length 5.5 to 7.5 mm, side port entry, anterior capsulotomy done using continuous circular capsulorhexis, hydrodissection, nuclear management, aspiration of the cortex, intraocular lens implantation, removal of the viscoelastic material sodium hyaluronate, and finally wound closure. So these are the steps of small incision cataract surgery. Now let us discuss the surgical steps of phacoemulsification. Now extracapsular extraction by phacoemulsification along with foldable posterior chamber intraocular lens implantation in the bag is the procedure of choice for cataract surgery. Now the steps of phacoemulsification: first, a clear corneal incision of 2.8 to 3 mm is made using the kerato. Second is the continuous circular capsulorhexis, that is the removal of the anterior capsule of the lens. Third is hydrodissection. Now it is a must for phacoemulsification because this procedure facilitates nucleus rotation and manipulation during the phacoemulsification. Now the next step is that the nucleus is emulsified and aspirated using a phacoemulsifier. Now the phacoemulsifier consists of a piezoelectric crystal which vibrates at 40,000 Hz. Now the different techniques to accomplish nucleotomy are divide and conquer technique and stop and chop technique. Fifth is that the remaining cortical lens is aspirated with the help of irrigation aspiration technique. Then comes the implantation of the foldable intraocular lens. Now this is done with the help of an injector. Seventh is the removal of the viscoelastic fluid so as to prevent secondary glaucoma, and finally there is wound closure. Okay, so these are the steps in phacoemulsification. Now let us look into the differences between phacoemulsification and SICS. Now the advantages of a phacoemulsification of SICS is that number one, post-operative astigmatism is less due to a smaller incision, whereas it is more surgical induced astigmatism is more in SICS because of a larger incision. Second is that visual rehabilitation is quicker in phacoemulsification, whereas it is slower in in SICS. Third is that post-operative congestion is minimal since it is performed through a clear corneal incision in phacoemulsification, whereas in SICS, remember, a conjunctival flap and exposure of sclera is done, and hence conjunctival congestion persists for about 5 to 7 days. Now another difference is that the intraocular lens, it is a foldable type in phacoemulsification, whereas a normal intraocular lens is implanted in SICS. Now some of the disadvantages of phacoemulsification of over SICS is the learning curve is more painful for surgeons, whereas it is easier to learn SICS. Phacoemulsification is machine dependent, whereas SICS is not machine dependent, and phacoemulsification is a more expensive process compared to SICS. So these are the differences between SICS, small incision cataract surgery, and phacoemulsification. Now for your vivas, commonly asked questions are: what are the advantages of phacoemulsification over SICS? What are the differences between SICS and phacoemulsification? What are the steps in the surgical procedure of small incision cataract surgery? So these are some of the questions that can be asked in your viva. Now moving on, let us look into the complications of cataract surgery. Now before doing cataract surgery, it is important to take a pre-operative evaluation and workup. Now here it involves most importantly the examination of the lids, conjunctiva and lacrimal sac. so as to search for any local source of any infection. Okay, so before the surgery we have to rule out presence of any infection so that we can reduce the chance of eliminate the occurrence of endophthalmitis. Next, visual acuity and fundal examination is done. Now this is because if the patient has any defect in the retina, like diabetic retinopathy or age-related macular degeneration, the cataract surgery will not completely bring back the vision to the patient. So it is important in such scenarios to give a guarded visual prognosis to the patients. Next is the general screening for diabetes, hypertension, cardiac problems, etc. So these are some of the pre-operative evaluation and workup. Now coming to the complications of cataract surgery. Now there are operative complications, early post-op complications and late post-op complications. Now under operative complications, we have the first is the superior rectus muscle laceration. Second is excessive bleeding during preparation and preparation of the conjunctival flap or during scleral incision. Third is incision related complications like buttonholing of the anterior chamber tunnel, premature entry into the anterior chamber and scleral disinsertion. Fourth is the injury to the cornea or lens with the sharp tipped instruments like keratome, and injury to the cornea can lead to Descemet's detachment. Fifth is iris injury leading to iridodialysis. Sixth is complications related to anterior capsulorhexis. Now this can have three types: escaping capsulorhexis, where the capsulorhexis it moves peripherally and may escape to the equator and posterior capsule. The second is small capsulorhexis, and such a type of capsulorhexis it predisposes to capsular tear and nuclear drop during hydrodissection. Third is a very large capsulorhexis, and here intraocular lens implantation becomes difficult. Okay, so far we've discussed, you remember the steps. The first is superior rectus bridle suture, and hence in such a step superior rectus muscle laceration can take place. Next is conjunctival flap preparation, and here excessive bleeding may occur. Then incision related complications, then injury to the cornea, lens, iris. Then complications related to anterior capsulorhexis. We have escaping capsulorhexis, small capsulorhexis and very large capsulorhexis. The next is next operative complication of cataract surgery is posterior capsular rupture. Now it is the most dreaded complication during cataract extraction, and it can lead to the nuclear drop into the vitreous chamber. Okay, so this is the one of the most dreaded complication, posterior capsular rupture. That is, if the posterior capsule is torn, the nucleus can drop into the vitreous humor. Next complication is zonular dehiscence, which is common in SICS. Ninth is vitreous prolapse and loss. Now it is another serious complication following accidental rupture of the posterior capsule. So if posterior capsule rupture takes place, then vitreous prolapse can occur. Now some of the pre-operative measures to control vitreous loss is use of hypoosmotic agents like mannitol and glycerol to decrease vitreous volume, and tab-acetylazomide can be used to decrease orbital volume. 10th is expulsive choroidal hemorrhage. 11th is nucleus drop into the vitreous cavity, and 12th is posterior loss of the lens fragments into the vitreous cavity. So these are the other operative complications of cataract surgery. Now the most dreaded operative complications. Okay, the most dreaded operative complications are posterior capsular rupture, nucleus drop into the vitreous cavity, and expulsive choroidal hemorrhage. So these three are the most important under operative complications of cataract. Okay, so again as a revision, the operative complications are superior rectus muscle laceration, excessive bleeding, incision related complications, injury to the cornea, lens and iris, complications related to the anterior capsulorhexis like escaping small and very large capsulorhexis. Then the most important ones, posterior capsular rupture leading to nucleus drop into the vitreous cavity and vitreous prolapse, then expulsive choroidal hemorrhage and zonular dehiscence. So these are the operative complications. Now coming to the early post-op complications, now a simple mnemonic to remember is fish and infections. Okay, so the early post-op complications are fish and infections. Fish, F for flat anterior chamber, I for iris prolapse, S for striate keratopathy, which occurs due to the endothelial damage to the cornea during surgery, and H is hyphema. Now the infections can be post-operative anterior uveitis, toxic anterior segment syndrome, and bacterial endophthalmitis. So these are the early post-op complications. So again, remember the mnemonic: fish and infections, flat anterior chamber, iris prolapse, striate keratopathy, and hyphema. Now the late post-op complications. Now the most important of the late post-op complications are the cystoid macular edema and after cataract. Okay, so these are the most important late post-op complications. Now cystoid macular edema, it refers to the collection of fluid in the form of cystic loculi in the macula. Cystoid macular edema, collection of fluid in the form of cystic loculi in the macula. Now it gives off a honeycomb appearance on fundoscopy. Okay, so remember honeycomb appearance in your fundoscopy. This can be asked as a 1-mark question. And it produces a visual diminution 1 to 3 months after cataract extraction. So this is the late post-op complication. The second is after cataract, which is the most common post-operative complication. Now it is the opacity. After cataract refers to the opacity which persists or develops after the cataract extraction. Now the causes for cataract after cataract are residual opaque lens matter or proliferative type of cataract. Now remember, the anterior capsular epithelial cells have the ability to proliferate. So the causes of after cataract, that is the development of opacity, is residual opaque lens matter or proliferative type of cataract. Now the types of after cataract are: the first is, there are 4 types. The first is posterior capsular opacification or PCO, posterior capsular opacification. The second is a dense membranous after cataract, as you can see in this diagram here. The third is Saumering's rings, and the fourth is Elschnig's pearls. So these are the 4 types of after cataract. The first is posterior capsular opacification. Now remember, the posterior capsule is the thinnest portion of the lens, and hence it is more prone to develop opacity. So the first type is posterior capsular opacification. The second is dense membranous after cataract. The fourth is Saumering's rings, and the fifth is Elschnig's pearls. Now the treatment of after cataract. Now for posterior capsular opacification, a YAG laser capsulotomy, that is, you make a hole in the posterior capsule so that the visual rays can pass. If you look into this diagram, you pass a laser and you make a hole in the posterior capsule. Now this will allow light rays to pass and vision can be improved. So the treatment for posterior capsular opacification is YAG laser capsulotomy. Then for surgical membranectomy can be done for dense membranous after cataract. Surgical membranectomy can be done for dense membranous after cataract and Elschnig's pearls. Now for Saumering's ring, if the central area is clean, then there need not be any treatment. Okay, so this is about after cataract, most common type of post-op complication. The types: PCO, posterior capsular opacification, where the treatment is YAG laser capsulotomy; dense membranous after cataract and Elschnig's pearls, where the treatment is surgical membranectomy; and Saumering's rings, which if the central area is clear, need not be treated. Now the other complications are pseudophakic bullous keratopathy, retinal detachment, epithelial ingrowth, and fibrous outgrowth. Now the importance of epithelial ingrowth and fibrous outgrowth is that it can lead to secondary glaucoma. So again, the late post-op complications, remember the most important is cystoid macular edema, which has a honeycomb appearance after cataract, pseudophakic bullous keratopathy, retinal detachment, and epithelial ingrowth and fibrous outgrowth, which can lead to secondary glaucoma. Now the fourth type of complication that can develop in after cataract surgery is intraocular lens related complications. Now this includes the UGH syndrome, U for uveitis, G for glaucoma, and H for hyphema. And the second is malposition of the intraocular lens. Now if there is inferior subluxation of the intraocular lens, it is known as sunset syndrome, whereas if there is a superior subluxation of the intraocular lens, it is known as sunrise syndrome. So these are the complications. We've discussed the operative complications, out of which the three most important ones are the posterior capsular rupture, nucleus drop into vitreous cavity, and expulsive choroidal hemorrhage. Then we discuss the early post-op complications, the code for which is fish and infections, flat iris chamber, iris prolapse, striate keratopathy, hyphema, and infections, that is toxic anterior segment syndrome, anterior uveitis, and endophthalmitis. And in the late post-op complications, we discussed the CME, cystoid macular edema, and after cataract. Then we discussed pseudophakic bullous keratopathy, retinal detachment, and fibrous outgrowth and epithelial ingrowth, which can lead to secondary glaucoma. And finally, we discussed the intraocular lens related complications like UGH syndrome, uveitis, glaucoma, and hyphema, and the malposition of the intraocular lens. So this is about the treatment of cataract. So in this lecture, we've discussed the various techniques of cataract extraction, that is ICCE and ECCE, intracapsular cataract extraction and extracapsular cataract extraction. Then we discussed in detail the surgical steps in extracapsular cataract extraction via the small incision cataract surgery technique and the phacoemulsification. Then we discussed the difference between these two techniques, the advantages of phacoemulsification over SICS. Now remember, these are all commonly asked viva questions. And finally, we discussed the complications of cataract surgery, and this is a commonly asked short essay. Okay, so this is about treatment of cataract.